It's time for another long case. Now, the big one, diabetes mellitus. So I'm going to do as before, go through the case, stop at some points and discuss a few bits and tips, and then I will continue the whole case. So this is a sample long case presentation, diabetes mellitus. Mr. X, 55-year-old gentleman, diabetic for 20 years, presented with generalized swelling for 2 months. Diabetic with generalized swelling. Thinking, maybe CKD, I don't know. Generalized swelling first appeared at face, then involved both lower limbs, then gradually became generalized. First face, then limbs, then generalized. Renal. This was associated with mild reduction of urine volume, anorexia, nausea, muscle cramps, progressive pallor. Wow, everything goes in favor of renal. Mild reduction of urine volume, anorexia, nausea, muscle cramps, progressive pallor, generalized pruritus, and weakness. Classic symptoms of CKD. But this was not associated with any chest pain, orthopnea, paroxysmal nocturnal dyspnea, persistent cough with shortness of breath, abdominal distension, hematemesis, or melena. So I'm excluding what? I'm excluding the other differentials of generalized swelling, such as I'm excluding heart failure, I'm excluding carpalminal, I'm excluding CLD or chronic liver disease. For those complaints, he consulted a local physician and he was prescribed diuretics. But his symptoms didn't improve. For further evaluation, he was referred to BSMMU. 20 years back, he was diagnosed as a patient of diabetes mellitus on the basis of typical symptoms and biochemical investigations. Initially, he was on oral anti-diabetic drugs, but he couldn't mention the name. He took his medication irregularly. 10 years back, he was switched to insulin 10 units at morning, 10 units at noon, and 8 units at night, a total of 28 units. He took his insulin irregularly and his blood sugar was not well controlled. Obviously, if you don't take insulin regularly, your blood sugar will not be controlled. He was not on regular follow-up. There was no regular follow-up with his physicians. For the last 2 years, he is taking premixed insulin 40 units at morning and 20 units at evening. For the last 2 years, he is taking insulin regularly and he is on regular follow-up with his physician. He had previous 3 total hospital admissions for diabetic emergency, 1 for hypoglycemic episode and 2 for hyperglycemic episodes. Very important, we're talking about the course of diabetes, how long the disease has been, and what are the drugs and other things. So what are the drugs that he was taking, injection insulin, what's the dose of insulin, and now what's the level of care and what's the control of diabetes. So we have covered all the important points. And then emergencies. He has given no history of focal weakness. We are starting to go to the macrovascular complication. He has given no history of focal weakness, exertional chest pain, so cardiac, leg ulceration, so peripheral vascular disease, or intermittent claudication. He has no difficulty or dimness in vision, diabetic retinopathy. For the last 1 year, he had tingling and paresthesia involving both upper and lower limbs, but not associated with any sort of weakness, peripheral neuropathy. He has given no history of resting palpitation, gustatory sweating, erectile dysfunction, abdominal fullness, bloating, alteration of bowel habit, constipation, diarrhea, recurrent urinary tract infection, any sort of bullous lesion or skin lesions. So those are all features of autonomic neuropathy. He had no history of other autoimmune disease such as hypothyroidism and connective tissue disease. He had three children. All of them are in good health. He has not had. He has three children. All of them are in good health. He is a businessman by profession. He is a smoker and he smoked for 10 back years. He is not vaccinated according to EPS schedule, but he is vaccinated against COVID-19. This is all about my history. On examination, the patient is mildly anemic. There is bipedal edema. Mildly anemic, and there is bipedal edema. JVP is raised 6 cm from the sternal angle. There are multiple rashes at insulin injection sites. Postural drop is present, evident by a fall of systolic blood pressure about 35 mm mercury from the sitting to standing position. Bedside urine for protein is positive. Other systemic examination findings, including vitals, are within normal limits. On nervous system examination, all the cranial nerves are intact. Fundoscopy reveals non-proliferative diabetic retinopathy, evident by multiple dot hemorrhages and hard exudates in both eyes at multiple positions. Examination of limbs reveal peripheral neuropathy, evident by all modalities of sensation, including joint position, vibration sense, and pain sensation, and they are impaired up to both wrist and ankle. There is no significant motor weakness. Other systemic examination, including cardiovascular system examination, are within normal limits. This is all about my history and examination. Now, from history and examination, my clinical diagnosis is diabetes mellitus with complications such as diabetic nephropathy with diabetic neuropathy and diabetic retinopathy. So, diabetes mellitus with all the microvascular complications. That is my history. So, what I have done first, I have talked about the main symptom. The main symptom was generalized swelling. So, that means the patient was having a feature of nephropathy, diabetic nephropathy, which is kind of like a nephrotic presentation. So, the patient has diabetic nephropathy, generalized edema, and I have excluded the other cause of generalized edema, such as I have excluded cardiac cause, I have excluded lung cause, which is cor pulmonale, and I have also excluded the chronic liver disease. Then I have gone through the course of diabetes, what sort of drugs he took, what are the then when he started insulin, how was his control, and how was his follow-up. And then I have talked about diabetic emergencies. So was he admitted for any emergencies? And I talked about the hypoglycemic episode and the hyperglycemic episode for which he required admission. Then I have gone through the chronic complications. First started with the macrovascular, so the focal deficits, the chest pain, and then the leg ulcer. Those are the macrovascular complications. So the strokes, the coronary artery disease, or peripheral vascular disease. Then I've gone through the macrovascular complications, and for macrovascular complication, I started with the neuropathy. He had peripheral neuropathy, and then I've also excluded the features of autonomic neuropathy. So those are the histories that I've talked about. On examination, it's very important that I've mentioned that the patient has edema. That is the main clue, or the main findings that matches with my chief complaint. The patient had generalized edema. So on examination, obviously, you will find the bipedal edema. And this is also held supported by a raised JVP, because whenever you have nephrotic syndrome, you have fluid retention. There is activation of the RAS and there is fluid retention, and that causes hypervolemia. So you have a raised JVP. Remember, if JVP is raised more than 5 centimeter, then that is significant. 5 or more, significant. And I have also mentioned the patient having the neuropathy, which is evident by the postural hypotension. The most important finding in general examination is the bedside protein. Obviously, it will be like 2+ or 3+. And nervous system examination, I have found the two things: fundoscopy revealing diabetic retinopathy, and peripheral nervous system examination revealing the diabetic neuropathy. So all in all, this is my case. Hope you liked it, and don't forget to hit the like button, put a comment, and also hit the bell icon. Whenever you have a opportunity to see my channel, go to the channel. If you hit the bell icon, you will find the new videos right away in your newsfeed. Okay, that's all our case. That's all about the case. Bye bye.